So we're at 3 o'clock Eastern, and I know we're all at different time zones, but I'd like to welcome everybody to our second Cbve town hall of this summer. And what we're going to do today, some of you are still joining. Kristen, do you think we should give them a minute to join still?
Sure, Kathy, I think that would be okay. I've already started the recording.
Yeah, I saw that. And so we'll go ahead and give people a minute or two to join. I don't know how many are already on, but I think people are still joining the meeting.
Looks like we have about 24, Kathy. So I think maybe waiting just maybe one more minute.
Okay. So while we're waiting, you can go ahead and put your name and school and your role in Cbve at your institution in the chat. And that way we'll know who was participating in this town hall. And we're really happy that all of you could join us today. And we know that some of you, many of you were probably here at the first town hall, but some of you may not have been. So we'll give you some orientation as to what we did at the last town hall. And Kristen, you can go ahead and advance the slide, please. So this is what our plan is for today. We're going to tell you about the first town hall and give a summary of the feedback that we heard from you. And then we're going to try to bust some myths that we've heard pretty frequently about Cbve and talk about why they're myths and not reality, and then have a wrap up and talk about next steps. Next slide. So many of you, as I said, participated in the last town hall, and we really appreciate that. And we did hear your feedback. So that's what we're going to share with you now. Next. So at the first town hall, and you can click through these, Kristen, the question. So the question shows, so there was the first question, we had breakout room discussions. And the first question was, what does your program envision as the biggest hurdle or barrier for implementation of Cbve? We wanted people to share successes, what's working in overcoming whatever the hurdle was, and then also share their frustrations or what they would need to help them overcome this hurdle. And then the second main question was, how can the AAVMC Council on Outcomes-Based Education, Veterinary Education, best support your needs for implementing and moving to this new model of education? So your presenters today are part of the Council on Outcomes-Based Veterinary Education. And what we wanted to do was present then the answers we got to these questions and then talk about the myths. So we divided the group that participated last time into 15 breakout groups, and the participants discussed those questions, and then we asked them to enter their responses into a Google Doc, and the Google Doc had an area for each group so that they could simultaneously have multiple people answering or entering their answers into the Google Doc. So we were collecting information from all the groups at the same time, and there was the opportunity for multiple people in a group to put the answers in. And so you might notice when we show you the frequency of responses that there's more than 15 responses for some of the themes that we picked out. And part of that is because multiple people in a group could enter answers. And then we also organize these answers into themes. So the Cbve Catalyze working group looked at these responses, and they were categorized according to themes that were noted. And then we looked at the frequency of the themes. So on the next slide, then you'll see these are for the biggest barriers or hurdles, and you'll see a number in parentheses after each of these themes, and that indicates how many times this theme showed up in the feedback in answer to this first question. So the one that had the most responses were educating and motivating faculty and staff about Cbve. So trying to explain what is Cbve, trying to get buy-in from the faculty and staff about Cbve, and helping to change mindsets by explaining how it's different from what we do now. So that was the most frequently cited hurdle for different schools. The next most frequently cited one was lack of faculty and staff capacity, and there were 14 with that. And so we can imagine in this last year and a half with COVID and all the things that have been going on with that, on top of trying to do any kind of implementation of curriculum change, and Cbve has been a real challenge. So that's a real issue, the lack of faculty and staff capacity. Then the next most common by 13 responses was assessment concerns, and we lumped everything about assessment together. So that included changing assessment methods, changing mindsets of the faculty related to assessment, the perceived conflict of assigning a grade versus trying to develop competencies, and then also graduate performance. Another really big hurdle or obstacle is basic science faculty buy-in. And this is, there's a perception, well, you'll talk about it when we get to the myths, but that Cbve doesn't really include basic science faculty. And so one of the suggestions is that preclinical milestones would be very helpful. And then the other thing that was a very clear message was that specific examples of implementation would help to make Cbve more concrete when it comes to implementation. That several people said, well, I understand the concept, I understand the basics, but I'm having a really hard time visualizing how this would work. And so if we could have some specific examples of schools that are doing different aspects of it and how are they doing it, that would really be helpful. Thank you, Kristen. And then some of the lesser cited challenges were the challenge of curriculum mapping, that it's tedious, it's very detail oriented, takes a ton of time, that some groups wanted a system for tracking student progress, meaning like an electronic web-based platform, that type of thing, that could be maybe implemented across schools. Some wanted more detail in the competencies. They felt they were too general for them to really envision how they would implement them. And then there was also the desire for an expert as a resource for implementation of Cbve, since schools don't have an expert themselves. Then accreditation was the last thing that individuals mentioned. Will Cbve be embraced by the various accrediting bodies, or, you know, if we map to Cbve, is that going to be a problem? We know that the council, the Avma Council on Education, has said that they will accept it, mapping to Cbve competencies, as long as we've got that crosswalk between Cbve and COE competencies. Other accrediting bodies are maybe a little bit different with that, but there wants some assurance that this framework will be acceptable when it comes to their accrediting body. So then the second question, and the one we really want to focus more on, is what support do we need for implementation of Cbve? So this is a summary of the responses that we saw. And this is in parallel with what we saw as the hurdles. So we said that the top concern was trying to educate everybody about Cbve and getting buy-in. So the top resource they want are materials for educating faculty, staff, and students about Cbve, and 14 comments about that. And some of the suggestions were having a centralized resource for faculty development that all schools could access, having online videos for self-study by faculty and staff, also for training them, and then potentially webinars, kind of like what we're doing today, where we can have questions and answers and present some things. And then another suggestion was video vignettes of EPAs and of competencies being performed at different skill levels that could be used to train our faculty and staff who are going to be assessors. Also, a shared resource for assessment was listed. And if you recall, back when the working group on competency-based veterinary education started, it was to develop an assessment resource or an assessment tool to be able to use. And so that's still on our agenda, to try to develop assessment resources and tools. And so some of the things that were asked for are best practices in assessment and standardized longitudinal assessment tools. And then again came up specific examples of implementation, that would be so helpful to see concrete ways that, even though everybody's curricula are a little different, to have some examples of how people have implemented Cbve in their context. And so the idea was posed to create a repository where these examples could be placed so that people could look at them and then be able to contact the school that had that particular implementation method, and then also to have question and answer sessions with those who have implemented Cbbe. We heard that you would like preclinical milestones to engage your basic science faculty more effectively, and that would be really helpful to go backwards, since in our current milestones, novice is meant to be the minimum level for entering the work-based place assessment time, or their workplace learning in their clinical time year, whether it's a year or more time. And so having milestones that are pre-entering into the clinical area would be very helpful to show where the basic science fits in. And then having a common software program that potentially could be shared across multiple schools that are AAVMC institutions. These programs could include student assessment as well as curriculum mapping, and maybe the suggestion was made AAVMC could create or purchase a system. There are definitely systems that are available, but they can be pretty pricey. And then expert assistance being available. Could there be a centralized expert that multiple schools could use, since many schools don't have psychometrician, or could there be a hotline where they could you could call and ask your question, and maybe it's not even a live hotline, but you could leave your question and then somebody would get back to you and help you with whatever your question or area of concern was that you wanted help with. Next. Okay, so that's an overview of what we heard from you last time. And now I'm going to turn it over to Jared so he can start off with one of these 5 common myths about Cbve.
Thanks, Kathy. And it's great to be with all of you. As Kathy mentioned, in our last several meetings that we've had, as we've talked with many of you and with others, it's been clear that there are some misconceptions about Cbve that we thought it would be helpful just to kind of clear up a little bit. So that's what we're going to do. And the first one that I'm going to talk about here is the idea that adopting Cbve requires you to have sort of a Cbve specific curricular model. The reality is that Cbve is about characterizing an outcome. So as you know, the competency framework, for example, or the EPAs, the benchmarks are all about identifying what outcomes are recommended for a program and getting to a day one general practitioner. And of course, the benchmarks are about how that progress would generally look. So having that information can be useful, and that information can be harnessed in a variety of curricular formats. I just want to share a paper with you that came from really briefly, it came from Kent Hecker and Claudio Violato in 2008. This is the best paper I've read that addresses this, but they had this remarkable data set, and we're able to look at a number of schools. If you go on to the next slide here, 116 different medical schools over 8 years. They looked at all of the curricular models that were at the time used enough to be able to show up in their model. They used a hierarchical linear modeling approach to look at what impacted student performance, including on their clinical reasoning and sort of clinical problem solving and outcomes. And what they found was that the most important variation in achievement was student level variation. And in fact, the variation that came from curriculum differences, whether you're discipline-based or organ-based or problem-based learning, right? Those are the common ones that they're used. They were just inconsistent, and they just really weren't there. They didn't find curriculum differences. When you look at literature more broadly out of medical education, you'd find the same thing, that the biggest source of difference in achievement is what students bring. And the second biggest difference is actually teaching practice rather than sort of broad curricular structure. So what competency-based a competency-based approach allows you to do is harness some of the proven strategies for improving achievement. And in this next slide, there are a few here you can see that, for example, the use of clearly defined learning outcomes has been shown in a number of studies to improve achievement. Informing students of what success looks like. So having clearly defined what competence is and informing them of that impacts achievement. Where it's been able to be implemented, mastery models, so models that are tied to competence rather than just time, have great outcomes for learning. And then frequent feedback. There's been very, very few things in the literature more broadly, really in and outside of medical education, just across the education literature that have been looked at more than feedback. And feedback has a huge impact on learning. Well, good feedback is tied to knowing what the outcomes ought to be and having processes built in for providing it, e.g., or in other words, processes like programmatic assessment. So what we would say is that there isn't a specific curricular model that would have to be used. The principles associated with a competency-based approach should be equally applicable regardless of the model that you're using. And I'll add, just before we go to the next point here, just, all of us are already preparing veterinarians to be licensed, and our graduates are licensed for day one practice already, and we're already aiming towards defined outcomes, which is defined by our accrediting body, right? All that the competency-based approach allows us to do is do that with a little bit more clarity and specificity than what our current tools allow. That's what I wanted to share, and I think we're just going to address questions at the very end, aren't we, Kathy? Yeah. Okay. So I'll relinquish the screen then. Thank you.
Thanks very much, Jared. So this is Jenny, and I'm going to talk about the next of the myths, which is you have to implement all 5 core components of Cbve at the same time. So next slide. So just like Jared was talking about, and he mentioned some of those core components already: programmatic assessment and teaching practices. So really, though, we have to review what the core components are for what competency-based education is, rather than before we can actually bust this myth. So these 5 core components were identified by Van Mellen and colleagues in a paper back in 2019, and they did a Delphi process where they asked a whole variety of people working in Cbme, so medical education, saying, what do you think are the really essential things, the essential characteristics that you need to have to be truly having a complete competency-based medical education program? And they came up with these 5 core components or 5 core characteristics. But the myth that I'm going to try and bust, which some people think is that if I'm trying to implement a competency-based program, I have to implement all 5 core components at the same time, and that's not the truth. So instead, we can look at these components, understand what we can do with these components, and then implement them at an appropriate time for our program, when it's good for our program, making sure that we're trying to implement the next one and the next one over time to get to these 5, but we don't need to implement them all at the same time. So let's talk a little bit about the 5 core components and what they are and how we might be able to implement them in your program. So the first component is the fact that outcomes are predefined, desired competencies with an achievement by all students as the goal. And that's a really important point, is what we're trying to say is if we really define these outcomes and then we can define how we can assess those outcomes, then we can assure that all our students are achieving those outcomes. And this is some words from Eric Hombo in a workshop that he gave for Cbbe in Ohio. So he said this, and he also said that competencies are derived from the needs of the patients of the society and then organized into these coherent guiding frameworks. Next slide. And so that's what we did for Cbbe. We developed a competency framework. Next, go on, Kristen. And we divided this framework, as they have in medical education, into domains of competence, competencies, and illustrative sub-competencies. And coming back to some of the points that were raised at the first town hall is what we want to say is that the domains of competence and the competencies really should be core across all programs. So that way we can compare programs and we can have the same outcomes for day one outcomes we want for all our students. This is really the illustrative sub-competencies that we can drill down on and that really help people with a little bit more granularity. And Kristen's going to talk a little bit more about that granularity in those illustrative sub-competencies. But that's where individual programs can contextualize their programs, their local cultural need and specific needs. And then we can use those competencies through curriculum mapping, through designing curricula, et cetera. And then the next one, components is sequence progression. So this is some sequence clearly defined sequences to explicitly define the progression of the student to identify their abilities going towards competence. Next slide. And so again, we did this through milestones in Cbve. Again, as I said, these are defined observable markers of an individual's ability along this developmental continuum. And just like with the framework, we can use these milestones for curricular design, for curriculum mapping. So this backward mapping and backward curricular design that we need with these outcomes in mind. And they're also really helpful because they're behavioural anchors, so they can be really helpful for developing assessment tools as well. And then Kristen also is later on going to talk about these preclinical milestones that Kathy referred to as well, about how we can back these milestones further into the curriculum to really help people, particularly around curriculum mapping and curricular design. Next slide. The third of these 5 core components is tailored learning experiences. And what this brings into this is this whole concept of time, that time is a resource for learning, not the basis of progression of competence. And so thinking about how can we tailor a student's progression around their individual competence in some manner, and then it's not necessarily based into time. So next slide. So let's think about time as a resource. And what our current situation is we're really often in a lockstep programs, and so our students progress in a lockstep manner. And part of that's because of the requirements of the COE, which is that we have to have curricula that extend over a minimum of 4 academic years. But can we think about this in a different way? And are there ways to use competence rather than time to determine progression within 4 years? Or at least think about, can we use competence as a way of defining achievement of a student, maybe within that 4 years, and then there's a potential for students to potentially achieve more within that 4 years or achieve a little less, depending on what they're doing around competence and depending on what the program needs. But it's trying to stop thinking about all students have to achieve exactly the same thing at exactly the same time and get rid of this lockstep way of thinking about time in our programs. And the next of the core components is competency-focused instruction. And this is instruction that's focused on competencies, their achievement. And this is how we need to then think about giving this instruction to the students. So having student-centered instruction instead of faculty-centered approaches. So to do this, we need to have a lot of faculty development. So getting faculty to understand the importance of student-centered approaches as opposed to the approaches from themselves, that we're focusing on outcomes rather than their inputs, and that we're trying to get them to think about how can we coach students along to achieving these competencies? How can we help students and coach students and give them all that feedback that Jared just told you was so essential in their programs so that they're able to achieve these competencies. So a lot of faculty development about bringing in these competency models, because it's not the way that they're often traditionally trained and think about educational models. And the last of these 5 core components is programmatic assessment. And this is, as Eric Hombo said, assessment that's planned, systematic, systemic, and integrative. But the really important thing here is that we have numerous direct observations and focused feedback that contribute to an effective learner development of expertise. So it's this partnership that we're developing with the students and thinking about how can we assess them. And we need to be assessing all the domains of competence and all the competencies, not just a few of these. We need to make sure that we develop a program of assessment that covers all those domains. We need to be thinking about multiple methods of assessment and multiple evaluators, doing this over time so that we're getting a variety of different assessment inputs, these pixels that we talk about with assessment that Emma's going to talk a little bit more about later on. And that we have to switch our thinking about assessment rather than assessment of learning, rather than assessment for learning. So that's the whole coaching model that we're trying to develop. So thinking about a different way of developing this programmatic assessment or a program of assessments. So again, just to reiterate, is that there's these 5 core components. You should know what these 5 core components are, but you don't have to implement all 5 core components at the same time. You can have any mixture of implementation. There's no benefit for bringing one in versus the other. It all just depends on where your program is. But obviously, we need to be getting to having these 5 core components in our program to have a truly competency-based veterinary educational program. I'm going to hand it over to the next myth. Thank you.
All right. Thanks, Jenny. So myth number 3 today. as we've already discussed a little bit, Cbve doesn't include basic sciences. So let's try to dispel this myth. The Cbve framework really gives us that 30,000 foot view, right? And if we think about the 9 domains of competence contained within that framework, it really is the overarching view down into our educational programs. But if we dive a little bit deeper, we have associated competencies for each of those 9 domains. And if you think about the mountain here in the background, that could be a competency, and this beautiful field of daisies below would be the illustrative subcompetencies to support achievement of that competency. And so the illustrative subcompetencies that have already been mentioned, that Jenny mentioned, really that is the level at which colleges and schools and programs are encouraged to customize and really individualize the framework to their own local or regional context. And so the daisies in this field would be the illustrative subcompetencies for one program, and maybe it's a field of tulips for another program. So again, that level is the level of customization. And then if we look a little bit more closely using this magnifying glass, we look at all of the detail around those illustrative subcompetencies or the daisies. And this is the level at which we really can then put in the discipline specific content that everyone holds so close to their heart. And so I want to come back to our myth as we think about this being an overarching framework and how we really try to understand that this is a framework that can really fit in across the program. So we've mentioned the framework itself is really something that graduates and faculty alike can use to visualize what should that graduate be able to do at the time of graduation. And then the milestones as a component of our competency-based veterinary education really allows us to see the learner progression and assisting both learners and faculty in helping place learners along that continuum for clinical training. So again, to dispel this myth, we need to look a little bit closer at the milestones. So when we think about milestones, milestones have been written in Cbve at 4 different levels. And novice level is actually written to be achieved by the time that student enters clinical training. And then competent is the level at which we expect learners to achieve by the time or at the time of graduation, knowing then across that clinical time, they would move through that continuum of advanced beginner, leaving the proficient level to be achieved in some time the year following graduation. Now, it's important to think about this learning continuum. We've outlined this as truly the continuum across the clinical program, or that time where we see students performing in that authentic or workplace-based environment. But how do we think about the fact that these milestones are written as these descriptors or narratives of learner progression for the clinical year? How can we translate that down into something where faculty can really understand better how to use the framework at their level? And so milestones really can be used, we feel like, to ensure learners achieve at least the novice level before entering clinics. And I think it's important to keep in mind here too, that some competencies could be developed to a higher level than novice before that time point even arrives, before the entry into that workplace-based training. So if we think about moving the learning continuum into the preclinical program, really, these preclinical milestones can help faculty understand how the framework really does apply across the program and can include basic science content, which is our myth right now. So let's look at an example, and this is kind of a big, busy slide. So let's take just a minute and think about the 3rd year of the program. If we think of these milestones as having to be completed by the end of the preclinical time, by the entry into clinical practice or clinical training, if you will, clinical training. So we have both the novice and the competent level, competent being achievable by the time of graduation. So this is for milestone 1.1. And so when we think about milestone 1.1, this is the one we just looked at. The way that I have set this chart up here is that I took the novice milestones and I just distracted them into each of their components. And so this is the same words, just separated into parts. And so I think that this is one way for us to visualize the progression of learning that can occur across the program and really encompass the entire framework. So if we take, for example, let's take 4E here, and the 4s and the E's, that doesn't really matter so much, but the milestone itself here that I've selected is selects and interprets routine diagnostic tests appropriately. That is an outcome that should be achievable by all graduates at the time of graduation. So in order to get to that point, the stepping stone or the block on that learning continuum really is something like the learner has to be able to interpret a diagnostic test accurately or appropriately, but they may not be able to use that in their educational experience at that time to advance the plan for that individual patient. And so if we consider that those are the milestones as written for the clinical training program, now let's consider what are the building blocks to get students to that point. So let's think about what could happen in that preclinical time. And in this instance, it's written for years 1 and 2 versus mostly across that clinical training program year 4. So if we think about what that could look like, we come back here to 3E, interprets test results, but may not use them to advance the plan. Well, a building block for that might be something as simple as selects the correct test to evaluate an organ system, or prioritizes diagnostic tests based on their benefits and risks. Well, herein, a learner is not able to do those things without foundation science like pathology or even clinical pathology. So these are the building blocks that move us preclinically into the clinical or the milestones that are written that students are supposed to achieve across that clinical training year. And if we move back to the very beginning of the program, here the learner has to perform core diagnostic tests and interpret those test results. Well, that might be something as simple as running a blood glucose. And so certainly that is a milestone that would reflect entry-level knowledge and skill. But that is something that we can certainly envision being built upon across that continuum of learning through the preclinical program to move us up into the novice and ultimately competent level of achievement across the learning continuum. So if we think back now to the original myth, we're trying to decide, well, is this or is this not related to basic science? I wanted to mention one more thing, and that's about this golden thread. And I've sort of talked about the learning continuum, but we really want to always think about working backwards, whether we're developing curriculum or whether we're thinking about milestones, working backwards to maintain that golden thread and keeping the final outcome in mind. Or milestone in this case is really important so that this learning continuum can move sequentially across the program. And then thinking about the myth itself about basic science, I already mentioned it's important to see those milestones as really requiring the foundation science. And if you think about this very basic, a milestone that a learner should be able to achieve in year 1 for performing diagnostic tests and interpreting a result. If you think about blood glucose as an example, the use of foundation science here is incredible. So being able to perform venipuncture requires knowledge of anatomy. It requires knowledge of species, understanding which venous access is appropriate for which species, and then thinking about diagnostic or interpreting that test result. Certainly physiology, that knowledge is essential for understanding glucose and its regulation and metabolism. So lots of foundation science in here. It's just not called out across discipline specifics for anything, because again, the framework and the milestones are written at a higher level, and then we come in and build with content. So basic science is truly the foundation of medicine and surgery. And while not explicitly defined within the Cbfe framework, we hope it's a little bit more easy to understand. The importance can't be understated. It is absolutely critical to our educational programs. So hopefully this goes a little bit further in dispelling myth number 3, that it's not just written for clinical science, that basic science has a huge component within Cbve. We're going to move to the next myth now. Dr. Reed.
Thanks, Kristen. So I'm going to talk a little bit about programmatic assessment. And the myth here is that programmatic assessment requires thousands of pixels to be any good. So let's go on to talk about what that means. So programmatic assessment really is sort of the collecting of multiple data points over many learners. So each learner will have assessments that they were doing, and then we sum all those assessments together. And what kind of picture does that give us? And the other question is, how many of those snapshots or data points do we actually need to get a good picture of what's going on? So an assessment on an individual basis, we can talk about individual assessment moments, which, as I said, are kind of snapshots of a learner's performance. So their competence, their deficits, their readiness to progress in the program, and each individual assessment moment gives the learner some feedback about what are their strengths, what are their weaknesses, how does that help them then shape their behavior or their learning and encourage them to direct themselves and direct their own independent learning. So this is sort of assessment on an individual basis. So really what we're going to talk about in terms of outcomes-based education is more this idea of programmatic assessment. And this is where each individual assessment becomes part of a larger system. And when you put all those assessments together, then it gives you this big full picture. And that's what you're going to be using to make high stakes competence decisions or promotion decisions, moving that student along through the program. So ideally, those individual assessments that you get on students, those individual assessment moments are actually decoupled or disconnected from those bigger decisions. Those are two separate things that we're sort of collecting and reviewing. So really what programmatic assessment is all about is that the whole is more than the sum of the parts. So student progression decisions, or whether or not students move through the program, and in some cases, in some outcomes-based systems, the rate at which they move, student progression decisions are really made by an independent group, ideally, that would be looking at that aggregate data. So pass-fail is not determined in the moment of that individual assessment moment, but pass-fail for a student is actually determined sort of stepping back and looking at a number of different assessments for that student. So the question always comes up about how much data you actually need. And I guess if you think about it this way, so the more data you have, the clearer the picture that you get to a certain point. So if you think about the picture that we have here on the left, it's a little bit fuzzy. It's a little bit, you can sort of tell what it is, but it's not as clear as it could be. And then as you move sort of to the middle and you move over to the right, you get more pixels in the picture. The picture becomes clearer and you actually get a better quality picture. But the thing to really remember with programmatic assessment is the more you collect, the clearer the picture, but to a certain point, because somebody has to actually collect all of that data and somebody actually has to analyze it. So if you have this big pile of data, but you can't actually analyze it and you can't actually see what the picture is trying to tell you, then it's not very useful. So it's better to do a really great job with less data than to struggle with way too much. And it's about finding that balance point for your program. So don't forget that this whole thing really is a work in progress. So your curriculum design creates your curriculum structure that should be aligned to the intended learning outcomes. And then your assessment system is also going to be the same way. So you're going to have these outcomes and your assessment system should be aligned to those outcomes. And the goal is ultimately to enhance student learning. And your assessment blueprint is going to say how each of your assessments fits into that bigger program of assessment and how your progress decisions are actually going to be made. It's important to remember that not every assessment has to be perfect. This really is about the sum of the parts. So the sum of all those assessments together is really what's going to give you the best view of that student. So aim to include a wide variety of assessments over time. And don't forget, we are looking at this over time. So it's all about longitudinal assessment of the student, and aim to use or develop the best quality assessments that you can, and then put those assessments in and collect the data out of them and sum it all together. So to try and help with this, the Cbve Analyze Working Group is actually trying to create a toolbox so that people will have options when it comes to assessment, and will understand more about what different kinds of assessment can be used for different skills or knowledge or various things. So what assessments would you use? What information do you get? And then you can think about how you would sum that together in your program to give you that complete picture of every learner and of every cohort that's moving through your program. And thanks for joining us today.
Okay, Susan? Is Susan up?
I am.
There she is.
Sorry for the delay. Our next myth is that everyone needs to buy in to begin the transition to Cbve. And as a start to countering this myth, let me ask a question. What proportion of your faculty have bought into your current curriculum? It's probably not everyone, yet the curriculum is still functioning. So let's look a little more deeply at why this might be. When introducing something innovative, there's always a spectrum of openness towards trying the new idea, from innovators to laggards. Innovators and early adopters are relatively willing to try new innovations. The innovators, even when it's just an exciting new idea, and the early adopters once the value of the idea is clear. And the tipping point comes when acceptance of the innovation starts spreading from the early adopters to the early majority of the population that you're sharing it with, so our faculty in this point. So if the early majority can see the evidence that the innovation works, and the late majority start to see that many people are implementing it successfully, they'll be on board. And by then you'll have 85% of your group that are committed to bringing the innovation to life, even while the laggards are slower to join the party. So next slide. So everyone doesn't need to buy into Cbve before making a start on implementing it. But we are talking about a paradigm shift from an input-based focus during curriculum design and implementation, like these individual paints and paintbrushes, next slide, to an outcomes-based perspective on this process instead, like this finished picture. This is our goal, and it means moving from a focus on what subjects are taught and assessed in the curriculum to a focus on graduate outcome abilities in service of patient and society. So the question is, how can we help our colleges make this shift? And we've already heard in this town hall today several suggestions for this. And next slide. And the first and most important step is to focus on why we're making this shift. So we need to better prepare our learners for meeting patient and societal needs as new graduate veterinarians in practice, whatever type of veterinary professional practice that might be. So this is the bigger picture of why we're doing this. But what are the pieces that we can help faculty embrace as we work towards this vision? Next slide. So Jenny outlined earlier the core components of Cbme and Cbve. So it's the clearly articulated outcome competencies, the sequence progression of these competencies and their developmental markers in those milestones, as Kristen talked us through, and then tailored learning experiences that facilitate the acquisition of these competencies. Competency-focused instruction that promotes the acquisition, and then programmatic assessment that supports and documents the acquisition of competencies, as Emma was just reviewing. So these are founded on the concepts of mastery learning and constructive alignment, or backwards design of curricula, as Jared outlined. So as Jenny explained, you can focus on starting
Your attention, please. Federal and local regulations.
Susan's in an airport.
In all
It's reminding
areas
us
that
to wear a
SFO.
mask.
Supporting safe travel.
Okay, thank you. So as Jenny explained, you could focus on starting at only one of these points, or maybe 2 or 3, depending on where your critical mass of early adopters is. So your curriculum committee could focus on curriculum mapping to the Cbve competency framework, or your clinicians could focus on developing a program of assessment based around the entrustable professional activities. So look for your early adopters and seek to build that critical mass towards that tipping point. So, or you might be in a position to work towards wiping the slate clean on your current curriculum and starting again from the ground up, implementing all the components progressively from year 1. I think few of us would be in a position to make that type of wholesale change. So next slide. So either way, there are 8 steps required for successful change. And you may be familiar with these already. So establishing that sense of urgency, the why are we doing this? Then building a guiding coalition to help oversee the implementation process and decide what part you will address first. Developing a strategic vision for what that's going to look like in your institution and in your local context, and initiatives that are aligned with that. And then communicating for understanding and buy-in using all of the methods that you have available to you. Then enabling action by removing barriers to people who want to make the vision come to life, but might be hampered by current policies or processes that get in the way. So seek to align these with innovation in creating those tailored learning experiences and competency-based instruction. And then, but this is obviously hard work. So creating those quick, visible wins is important to encourage people to keep going in it and keep going in the effort. And then as you make progress, consolidate your gains and propagate change by identifying what next goals you will address. And then finally, anchoring the new approaches in the culture, and by anchoring what you've implemented for Cbve to the outcomes for your new graduates, and in better meeting the needs of your local context and society. So gaining feedback on how your graduates are performing in practice is an important way to provide the evidence, particularly you remember for those late majority to say, yes, this is worth getting on board. And finally, the laggards will join us. So I'll pass on now to Jody.
So before we do closing, we have a few minutes and you've been given a lot of information. You've gotten a great summary from Kathy from the first town hall meeting to give you some feedback about what your group collectively is looking for. And then today you had the opportunity to hear some very good salient arguments made for busting those 5 myths. I'd like to give you about, we have time for a few questions or comments people would like to offer before we close, and we will end on time at 4 o'clock. But I wanted to make sure that people have an opening. I know there was one comment, where can I access the first town hall recording? And I believe Kristen put that up, that it's on the website for Cbve and the Cove, that you can find town hall number 1. And I'm not exactly sure when 2 will be available after they put this together, but we intend to make that available. So floor is open for any questions on any specific myth, any other thing that you gleaned from today's town hall. And if you want, you can put them in the chat, or you can just unmute yourself and ask a question. So I'm going to say this is a town hall meeting, and we look for participation from our participants in providing something. Let me ask a really simple question. Could those slides help all of you, at least the myth busting with your faculty directly in your programs to help them better understand and clarify perhaps some nuances or issues around Cbve? Absolutely. There you go. Are some of you planning on using those slides with some introduction or something? Are some of you planning on using these slides with your faculty as a part of faculty development? Yeah, I had a feeling that might be the case as people are going through and probably frantically writing some of the great citations that each myth offered and places where you could find some great resources. So a number of you are looking for that information. So I'm going to ask another question. For some of you, or how many of you, how many myths did they bust? Did you have any of those myths or preconceived notions about what you needed to do or should do about adopting or embracing competency-based education in veterinary medicine? Were any of those new, or hopefully maybe you already knew them all? That would be great if you did. Great question. So someone said, maybe with some help to wrap around this, but how should colleges best go about combining Cbve with the assessment of Avma competencies? And I'm going to turn that over to my colleagues because some have actually navigated that already with the competencies, and either Jen or Kristen or Emma, whatever, in terms about the mapping that already exists. Would someone like to take that from the group?
I'll just start by saying that we do have a crosswalking document. Jenny mentioned, I think it was Jenny, about crosswalking. Somebody, sorry, forgive me. But we do have that document that's been created to show you how Cbve fits into the Avma COE 9. And so using Cbve, there you have a much broader picture of what a veterinary graduate does. And you'll find, if you look at that document, that all of the COE 9 are contained within Cbve, but Cbve is not. There are extra things that are not included in the COE 9. So it's a pretty interesting perspective when you look at the two frameworks side by side. Jenny, Emma, anyone else? Kathy, Jared, anything to add?
Just to make the point that the COE did sign off and say that if you've mapped to the Cbve domains and competencies, and you can show how they align, and we've shown in that crosswalking document how they align with the COE 9 clinical competencies, then they're fine with that. So if you've done the mapping to those domains, then they're fine that you're also mapping to the Avma domains as well.
And just to point out that the crosswalk is on our new website, right?
Yep.
Yes, and I forgot to mention on the last slide, we will have the web address, cbve.org, but you can find lots of interesting information there.
One thing that was brought up in our mock accreditation visit that we did here recently, we had a few mock visitors just to help us get organized for our actual site visit. And a couple of the people had been COE site visitors in the past. And one thing that they shared was they weren't sure how much the site visitors themselves might actually be versed in Cbve. And so I think relative to that question that was asked, I think it's probably a good idea that if you have mapped everything to Cbve, that you still do show or demonstrate how things actually line up with the COE competencies as well. So for example, domain 1 in Cbve has an awful lot of overlap or coverage with the first COE 9 competency. And so those align very well. So I think it's kind of important to, if you had a diagram, that you would label it with both of those things. So it's quite clear to the visitors when you're showing them those outcomes where that coverage actually occurs. And hopefully over time, more site visitors will become better versed in Cbve. It seems like the COE is getting much better versed in Cbve, and hopefully eventually we can make sure that everybody's kind of familiar with the system.
Thank you all. Great responses. And the bottom line is that the COE is familiar and that the competencies that appear in Cbve are actually perhaps a little more comprehensive than those that are in Avma. There is an interesting question here, and I think it relates to the myth about the basic scientists, and somebody is concerned that it may take preclinical folks a little more convincing that they have a place in the Cbve coming from clinical perspective. So that's just a point that people are making. And there's some other comment that there are some who are saying perhaps site visitors are not as well versed. And I would use the word yet. They will get better as they see more and more programs implementing different phases of Cbve in different capacities. And the fact that the mapping is there, they certainly have accepted that. So, and I don't know if there's any additional things you would add for those who are the preclinical and basic sciences for anybody in the group. And I know who had that myth. If there's anything additional you might offer, I'm not sure.
So Jody, I think that, part of that comes from, because I know we're somewhat struggling with this ourselves, is that shift, which is really hard cultural shift often in a college around being faculty focused versus faculty-centered versus student-centered. And particularly when we have faculty-centered and faculty very naturally really embedded and engaged with their favorite basic science topic is wanting to teach that. And so, but taking that focus away of this is what I like and this is what I want to teach, and I'm not necessarily relating it to an outcome versus I'm sorry, you now have to focus on that outcome, that golden thread that Kristen talked about, and saying we really want you to focus what your teaching is on what students actually need to learn and the outcomes we want them to achieve. That is a significant cultural shift, Sheena, and it's not going to be an easy one, but we just have to keep on saying we're focused on student outcomes. We're focused on the student, and we need to be student-centered in our teaching and our learning.
Thank you so
one
much.
Of the things, yeah, thanks. One last comment, Jody. I know one of the things that's really supported us in our redesign to competency-based education is having this integration of basic science faculty working with clinical science faculty in designing new courses, so that everyone sees the starting point and the end point, and having those outcomes in mind and working backwards towards that end goal of the competency has really been helpful for us. Not an easy road at all, but everyone has a part to play, and everyone is just as important as anyone else. And so I think that integration piece, which is so critical to competency-based training, has really been one of the pieces of our puzzle that has really helped those early adopters make even a greater shift of more and more faculty to come on board.
Thank you. And I am going to go to the last closing, but somebody asked for the link for the article or whatever the document.
It was a document, Mandy, that was sent out to everybody. I can send it to you. So there was a document that Karen Brandt sent to us. And
I believe that's posted on the website as well, Jane.
Well, yeah. And that was shared with all the associate deans at the time. So
correct.
So we've got that
I wanted to clarify, it is a document, not an article.
Yep.
So after having gone to, some of you have gone to one, and some of you have gone to two, or going to hear the recordings, or both. We have 3 questions we'd like you to answer in the chat directly. And if you would put your name and your school, it would be helpful. So the 3 questions are going to stay right here, and you have like about 3 or 4 minutes to put down, has the town hall session or sessions been useful to you? And the answer is either yes, no, and why or why not. That's really helpful for the Cove in terms of future planning. The second question is, how frequently would you like to have these town hall meetings? Quarterly, semi-annually, twice a year, annually? So that helps them for planning purposes in the future. And based on the first town hall was one that went into smaller Zoom groups and was interactive. The second town hall format's a little different, where we provided the summary and then offer some cogent or key salient points about what they had learned and helping to advance everybody as part of a understanding or better understanding of the myth busting. So it actually had a knowledge piece that they were translating. So with those 2 different models, is there anything specific you would like to see in a town hall in the future? And that could be either content or a model or a hybrid or whatever that again helps our group do really respond to the needs of its community and trying to serve what it is you need. And again, those are two different formats, one that we get information from you and are able to have some dialogue in smaller groups, and the other where they present some information that may help each one of you in your individual programs, along with some summary about what it is you as a group feel or need about CBE. And we appreciate your feedback on this. Again, the community, you are the community that they're there to help to serve. So they're trying to really respond to the needs of you as the community of learners in terms of how this advances and what is needed. Not any much differently than what your own students will be. And we do.
In the instance of time, Jody, I'm going to go ahead and put our website up here.
Absolutely.
Jenny, do you want to mention the website?
Yeah, sorry, I'll unmute myself. Yes, while you guys are writing down, just to mention to you that we're actually about to release our first newsletter. So the other thing that we're doing is producing a newsletter, probably 3 times a year. And so in that newsletter, we're going to give you updates, some articles, some recommended reading, some examples of schools that have implemented Cbve, or at least what they've done, some quick examples of what some schools have done about Cbve. So if you want to sign up for the newsletter on the website, so www.cbve.org is as right at the bottom of any of the pages. You have to go right to the bottom of the page. You'll see that little thing that says sign up for the Cbve newsletter. And you just need to put in your email address there, and then we'll automatically send you out any of the newsletters as we develop them. So as I said, the first one hopefully will be out next week. We're really excited about it. And thanks very much to the advocate group for getting that together. But we are going to be producing some newsletters to help spread the news about Cbve as well.
Thank you so much. These are great suggestions, and we very much appreciate you providing this feedback in terms of facilitating the work of the members of the council. Great suggestions. And while they're doing that, if there are any additional questions that people would like to ask, we are still here.
I know some of you are probably going to have to start jumping off for your next meeting. Thank you all so much for being here. And really just thank everybody for your participation, and thanks to all of our council members that are here and our working group members that are here. And we'll see you guys next time. Stay tuned. And for those of you still chatting, we're going to wait till we don't have anybody left in our meeting. So keep sending us your information in the chat.
Don't forget to look at the newsletter. Got great stuff, and for future town hall meetings that will be coming based on what we're getting with your feedback.
Thanks everyone for coming.
I'm going to go ahead and stop our recording now.
That's great.
Thanks for being here.
So I